Hello, good evening and welcome. Thank you so much for joining us tonight for the adult vaccination update. My name is Alison Burgess. I'm the the manager at the Primary Healthcare Improvement Team here at the PHN. And our team's role is to coordinate and facilitate education and training sessions for general practice in our region, including the sessions like we're doing tonight. Before we continue on, I just want to make sure that just making sure the slides are working. There we go. I'll make sure we take a moment to acknowledge the traditional owners on the land on which we're conducting this from today and pay my respects to their elders past, present and emerging. Just a little bit of housekeeping, just to make sure we're all on the same page here. So everyone who's dialing in tonight you're automatically on mute, so you won't be able to speak to us at home, but you can absolutely interact with us. You'll notice that you've got a little panel. Generally it sits on the right side of your screen, where there's a little box where you can type in questions, and we encourage you to put any of your questions in there. We've got one of my staff, Madeline, who's behind the scenes keeping an eye on all the questions and some of the IT stuff that's happening there. So please put any of your questions in there and we'll endeavour to ask them along the way. We may ask them during the session at the end of the different segments, or depending on how we're going, we might wait until the very end to get some of those questions. We want to make sure that we get all the great information covered tonight. You'll also notice there's a little chat box that you can use, and you're welcome to, if you have any general little questions not related, so maybe some IT stuff, Madeline can talk to you in the chat box there, so you're welcome to use that. And after the session tonight, we will make sure that we send through an email to the email link that you registered with that has any of the extra information or resources that go along with the session, including the slide set, and of course that all-important evaluation survey. So if you could take a few minutes to fill in, that would be greatly appreciated. It's really important for our reporting and making sure that our education is really relevant to you guys. While I have your attention, I'm just going to do a little bit of shameless plugging about different things that we've got coming up here at the PHN that might be of interest or relevance to you. Some additional education sessions. Now we've all got so much more time at home to do education. You might be keen to attend some of these. Coming up very soon, we've got the CAT Plus and COVID webinar sessions. Practice managers meeting webinar. So generally in our catchment Northwestern Melbourne PHN region, we like to hold practice manager network meetings. So generally we actually hold them out in the suburbs, so in the west, in the north, in the far north and in the central areas, where we get the practice managers in those regions to come together, do a bit of networking, do a bit of education stuff. Obviously we can't do face-to-face at the moment, so we're still wanting to run these sessions via webinar. This session is going to be a little bit focused on pandemic planning, obviously quite topical at the moment. Obviously not region-based this time, so it's really just picking out a date and time that suits you to dial into that one. So we highly encourage you to come to those. And for practice nurses, we've actually got your meetings coming up in May, so keep an eye out for those. A little bit later in the month, we've got the SDI and PrEP, an update for primary care webinar. Really good, interesting session, that one. SDIs are particularly prevalent in our catchment, so really important that general practice is up with the knowledge and all of that sort of thing, so highly encourage that one. And then also later this month, a webinar on using My Health Record for both specialist and practice managers. So you're able to sign up for those on our webpage. I always like to mention in our webinars and education sessions our think tank opportunity. So just to give you a bit of a spiel about what this think tank actually is, basically we're seeking a pool of primary healthcare professionals who want to help us or provide advice and input into the work that we do here at the PHN for our region. So we want GPs and nurses and practice managers and pharmacists, etc., to be able to sign up to this pool of people in our think tank. And basically, the bigger a pool of people we've got, the more people we have to consult with on the work that we do for you guys in our region. So if you were to register for the think tank, which is just a simple online survey that you fill in for us, basically you're signing up to hear about a range of opportunities that you could become involved in. And this could be things like you could become part of a working group, participate in consultations, you might be involved in reviewing or providing feedback on particular resources that we're developing to support primary care in our region, be in tender panels, be a mentor, be involved in or even present at some of our education sessions, or even contribute to our sort of general practice newsletters. It's really important to note that registering for the think tank doesn't mean you're actually obliged to contribute to projects, but what it does mean is that we send you the opportunities for consideration as they become available. So you get to choose which projects you want to be involved in and how deeply you want to be involved, and it's really up to you if you're interested or have capacity at that point in time. And of course, where possible, and in many cases, we do actually are able to pay you for your time for that as well. So if you think it's something that you might be keen to maybe be a part of or see what it's about, do let us know. It's just a simple registration link that's available on our website, and we'll make sure that Madeline chucks the link to register that in the post-event email as well. With the COVID stuff, just some reminders they've asked me to mention to you guys of basically staying up to date, the 4 S's that they want you to make sure you're doing at your practice. So making sure you're up to date with the quick reference guide that the DHS is providing. We're obviously putting out a heap of updates on a very regular basis. We know that the COVID information is changing rapidly, starting to slow a little bit now, but still lots of changes happening. So make sure you're signing up to those if you haven't already, and just all the other alerts to be aware of, and continue doing the great work that you're already doing for us. And as of last week, some of you may be aware, and you may be up on this already, that Health Direct video conferencing, the platform for that has become available free for general practice in our catchment. So if your practice would like to take up the opportunity to use that platform for your telehealth consultations, you can access through the PHN, where we will onboard you, get you signed up and onboarded on using that. And it's just a simple expression of interest form, which can also be found on our website as well. So make sure you get on top of that if you're keen to use that one. All right, I think that's enough of me taking up the time. I'll just do our little intro and then we'll hand over for the presentation for the evening. So we're super lucky tonight. We've got Dr. Peter Eizenberg giving his time to present tonight. He's a GP with over 30 years of experience with a real special interest in whole of life immunisation, travel vaccines and public health, and so much experience being part of lots of advisory committees and boards and things related to immunisation. So really is the guy in the know, and always a great, very, very detailed presentation. So certainly make sure you chuck your questions in there as well. So Mads, I might get you to swap us over to Dr. Eizenberg, and I'll leave you to it.
Hi, thanks Alison for that great introduction, and I'm just checking you can hear me and see the slides. Please let me know otherwise. I'm presuming that that leading slide is visible. I'm not sure, I can't hear you at all, so I'll proceed on the understanding, but somehow you'll get a message to me if it isn't working. So folks, welcome to tonight, and it's a very big topic, group of topics that we're going to get through. The general, not quite advancing here. There we go. So just a disclaimer and declaration of potential conflict of interest is customary. Those are the committees that I have worked for in representing general practice in immunisation around the country, both in government, academic, industry, and also for divisions, GP networks and research as well. And I undertake that I'm paid for my time involvement and have no other interest or shares in vaccines or companies, pharmaceutical companies. So these are the topics that we want to cover tonight. And it's quite a range of things that, that you and I as vaccine providers in the community need to have our minds around. And we're very distracted at the moment with the top line item there. But these other issues are something that are very important for us to keep our eye on, as they are important needs for our communities. And we'll try and cover all of these tonight. To just mention COVID-19 at this point, to emphasize that we're going to get our minds around what flattening the curve really means and what our contribution to it can be best. And also what happens when the curve doesn't get flattened, and at what point does our compliance in the community matter. So we're going to cover all that. Perhaps like you, you're probably feeling that this represents the exponential graphs that we seem to be preoccupied with, and that's certainly true for me on this slide. But what I'm going to request is that we now is not the time to talk about coronavirus, because I'm going to deal with this at the end of the presentation after we've dealt with the other important aspects, current flu vaccine program and other associated topics. So I'm going to move the coronavirus section to later in the program. So let's move straight into a continual issue for us in Victoria and elsewhere in Australia, and that is measles outbreaks and why are they continuing. I wanted to start with this very, I think this is a beautiful slide. It's so uncluttered. It's the very first edition of the NH&MRC immunisation schedule back from 1975. And it's a thing of beauty to see how uncluttered it is, just to compare to our current schedule, which has been updated in April. So first point, our previous editions of November, we're getting editions updated a couple of times a year, and April is a new edition with some minor changes from previous, but important to be up to date with the latest. And of course, this is assumed knowledge for tonight, and the reference for the Victorian schedule for the National Immunisation Program. And when we move to the second half of the child program, at 12 months and 18 months is where measles, mumps, rubella vaccine features. And we see the MMR first dose at 12 months of age, and at 18 months, the second dose of MMR combined with the varicella vaccine, varicella antigen in the vaccine. And just to remember, this is now our entire schedule, just to step through adolescents, adults, and of course, additional at-risk groups, where measles features again for children as a relatively new introduction. Last year it was introduced, and it continues here for infants from 6 months and before 11 months of age prior to overseas travel. Not that there's much overseas travel happening anymore at the moment, but that's later in the program. But certainly for those children who did have indication for this, we've been giving an earlier dose, which doesn't count for the 2 required doses for infants having measles, mumps, and rubella vaccine. So if children did have a extra vaccine, an early vaccine to protect them for exposure while they travel, protect them from exposure while they travel, then they will be needing their 12 and 18-month vaccines on time with a minimum interval of 4 weeks from a prior MMR vaccine. So why are we needing to have such a focus on measles vaccination and not just for infants at the right time, especially for infants at the right time, but let's go back to that beautiful slide and just point out the important issue that has set up a problem for us now that is resulting in a lot of outbreaks. We've got here the 12, this is back in 1975 on that first NH&MRC immunisation schedule, and there was measles at 12 months of age. Note it was monovalent measles in those days. And then at 12 to 14 years, it was rubella, not measles, and it was only for females. So we see back in 1975, there was no second dose of measles vaccine for anybody. It wasn't until 1994, this is now the 5th edition of the NH&MRC childhood immunisation schedule, where measles, mumps, rubella in a combined vaccine that included measles was given as a second dose. So here is the first one, I should have highlighted that. There's our 12-month measles, mumps, and rubella. And at 10 to 16 years of age, the second dose of measles. So this is 1994, before 2 doses of second dose of MMR vaccine was introduced. And so during all that period, there was some incomplete vaccination in terms of long-term protection. And that's why we're getting the outbreaks that we see. This is the latest outbreak identified in Victoria, and we get these alerts several times a year as new measles outbreaks appear. And, this was just the headline from last year, but last year we had a number, going back to here, I think this was the third, 4th of March was already the third case in Victoria. And this is the surveillance chart for measles for Victorian figures since 1991, with the events, that is individual reports of cases, and showing gradual decline. The black is the rate per 100,000 in the community, and it was virtually almost eradicated back at that time. And then it's crept back again, and we see last year there were 57 cases, and they've ranged between 20 and 75 cases over the last 5 to 6 years. And the age distribution that we see here, the youngest age, well, before 12 months, they're not protected at all. And these ages going up to 40 to 50 years of age, and it's an important severe disease, measles, and it rapidly spreads, and it's got a very high rate of spreading from person to person. So we're seeing all the outbreaks every year, and we have for a number of years, and we're still going to see a few unless we're diligent in identifying the cohort that we need to focus our vaccination on. It was a particular risk in people travelling overseas and returning with measles and spreading through unprotected people. So these are the groups that are at particular risk of measles. That's anyone planning overseas travel, anyone born during or since 1966. Now, this is a magical year, 1966. It's considered that people who were born prior to the 1st of January 1966 are considered to be naturally immune to measles because of the high level of circulating disease in the community. And so the at-risk group is anyone born during or since 1966 who does not have documented evidence of receiving 2 doses of a measles-containing vaccine or evidence of immunity on serology. Unvaccinated infants are particularly at high risk of contracting measles, and so we can vaccinate down to 6 months of age as a dose for protection for particular risk, either travel overseas or local outbreaks that are occurring. And so the indication has been downwards extended to 6 months of age for those risk groups. But the first dose of measles, mumps, rubella vaccine in combination is given at 12 months of age as part of the National Immunisation Program. And if they did receive an earlier dose, then they still need to have their other 2 doses. The earlier dose was not is a funded dose, and if they had that indication, and the 12 and 18 months is also in line with the schedule. Other recommendations for groups include all adolescents and adults born during or since 1966, as we mentioned, who do not fit the criteria of being considered immune. People born before 1966 don't need a measles-containing vaccine unless they happen to have serological evidence indicating they're not immune, in which case they should receive protection from vaccine. Just to bear in mind that MMRV combination with the varicella is not recommended for use in people aged 14 years or older, and live vaccine contraindications apply to MMR and MMRV combinations, that is contraindicated to immunocompromised people and to women during pregnancy, and it's preferred to vaccinate a month earlier than pregnancy for protection. Minimum interval of a month. So the recommended age, as we mentioned, has been lowered from 9 months to 6 months. and those are the indications that they may need to receive an MMR vaccine. For post-exposure prophylaxis, infants from 6 months can be offered MMR vaccine in place of normal human immunoglobulin, preferably within 72 hours after exposure. And finally, NCIRS put together a slide to try and clarify the complicated areas. I think I would consider this slide to be more complicating than clarifying. So just to summarize, that is the take-home message. So we should move forward to the 2020 seasonal influenza program, as there's a lot to cover in this. Flu has been anything but typical for the last few years. So we're seeing year-on-year chart here for Victoria, year-on-year figures for notification of laboratory confirmed. These are influenza-like illness, not laboratory confirmed, but the spread of influenza-like illness. And we'll move to laboratory confirmed in a moment. This is the Australian figures with the green representing this year to date. And we can see that we're on a fairly lower level of flu, back to what we call normal activity. I don't know if the word normal can normally be used anymore, but there is where we're at the moment. And we see that last year, the 2019 graph shows this area under the graph larger than anything before, even 2 years earlier when we had a very high peak. In between, we had a very low peak, the lowest we'd ever had, followed the highest we'd ever had. And this is the largest number we've ever had last year. Just to give you a hint up here, so ignoring 2020 data to date, last year we had over 300,000 confirmed cases of influenza. The year before, just under 60,000 confirmed. This is nationally. And the year before was called our largest year, was 250,000 confirmed, laboratory confirmed cases. So flu has been doing something different every year. And this year, no doubt, it's going to be unpredictable. All of our social distancing for COVID is probably going, we hope, will result in less flu. However, we don't know the effects of flu plus COVID together, and we will just have to watch and see what this does. We certainly know that this year, with COVID in the community, we do not want to have coexistent flu, because flu is preventable by vaccine, and we can keep people out of hospital from flu by vaccinating, and we need to preserve as many hospital beds as possible for COVID. Just a summary from last year's flu season, just a few things to mention. It was a very big year. It had the highest interseasonal flu activity, that is flu prior to flu season and beyond normal flu season. We had the highest number ever of lab confirmed cases, and after the year before being the lowest, and the year before that the prior highest. High activity was April to June, over 10 times the usual level in numbers, with an early peak and a long season. There was an extended activity of influenza-like illness, including flu, between March and October, with that broader peak we saw, and a lot of coverage about the season. The year was actually mainly influenza A with the H3N2 strain, followed by the 2009 pandemic strain of H1N1 that's been in circulation since 2009, and there were some Bs as well. FluCam, this is representative of the severe flu that results in hospitalisation intensive care cases, was also the highest high number of hospital admissions last year, and of interest, a large proportion, between 6 and 10% each year, of people hospitalised are admitted directly to intensive care. And most hospitalisations were due to the H3N2, and then some B, and a smaller number of the H1N1 resulted in severe disease. Deaths are always difficult to measure, and you'll see a wide variation in reported deaths, because Flu deaths can be reported either as direct death due to influenza, that is, contracted flu infection, overwhelming sepsis leading to death. That led last year to nearly 1,000 deaths. The year before, much fewer. But the other unrepresented impact of flu on death rate is that the majority of deaths, probably 3 times that level, are deaths due to influenza causing destabilization of fragile other disease, like fragile cardiac failure, diabetes, renal disease, resulting in death from the underlying condition of flu, but the reported death is renal, diabetic, or cardiac disease. Lab-confirmed flu in Australia last year varied enormously from state to state, both in the duration, the amount of interseasonal activity, and also the number of waves that occurred through the season last year. So we had a very broad, a very high, and an irregular distribution of flu around the country. And in terms of laboratory confirmed flu cases, the different strains are represented here. As you can see, the majority at most places, most times, and most years was flu A. The red are untyped, so we can't really distinguish whether it's H3N2 or H1N1. The yellow is the confirmed H3N2. The green is B. Just to give an indication of severity and notifications and severity, up to the point when this data was closed, the notifications represented there and the deaths there, it gives us a case fatality rate of 0.29%, so 0.3% for last year's flu season, and they've ranged over the years from about 0.2 to about to 0.5. That is a crude case fatality rate. We'll look at this with COVID later in the session, but the crude fatality rate is simply dividing the number of deaths by the notifications so that we get a percentage of how much was fatal from what was known. Now, there's a lot of variation that make this crude case fatality rate a very difficult thing to put a lot of meaningfulness on it. Number one, it depends on how much testing we do. If we do a lot of testing, as we did in 2019, we did a heap of testing and we found a lot of disease. Had we not tested so much as in the early days, we wouldn't have found as much. We suspect that there was a lot of flu out there last year, but it's also a lot of testing detecting this. In terms of vaccine effectiveness, there are different measures for each of the strains and each of the age groups, and also looking at people not admitted, that is mild to moderate flu, versus people hospitalized. And for last year, it was around a 50% effectiveness in terms of reducing incidence of disease. Flu vaccines vary with the strain and the year and the behavior of the virus in between. And flu vaccination is aimed partly to prevent flu infection and therefore spread to vulnerable people, but mostly it's to prevent severe disease, hospitalization, and death. And so vaccine effectiveness at preventing severe disease is what it's all about. And the final slide for this part of the flu presentation is to demonstrate the different mix of strains that affect different areas at a particular snapshot in time. So on the 17th of January this year, around the world, these were the different mixes of Bs and As and which As were circulating. And if we were to enlarge Australia and have a look at a snapshot through a typical week-by-week flu season in Southern Hemisphere flu season, we would see this type of picture at all the different areas around Australia. So what strains circulate when and where varies enormously. The virus can determine where it wants to go. Therefore, all of that information helps inform the Australian Technical Advisory Group on Immunisation together with the WHO to determine what the vaccine program for Australia is going to be. So all of that helps us to helps government to determine, and the vaccine strains are actually selected about 6 months ahead, because that's how long it takes to manufacture vaccines. And therein is a problem that affects vaccine effectiveness, because as the longer the time interval between when the vaccine is, which strains are determined to be likely to spread, and when the vaccine's manufactured, rolled out, administered, and people have protection 6 to 9 months later, the vaccine, the virus can have changed. It's genetically, its mutations genetically alter its properties for how sensitive it is to vaccine. So these are the key points that we've been circulated to follow for this year. And the important things are that it's all the vaccines in 2020 are now quadrivalent. There are no trivalent vaccines licensed or available in Australia for this year. Also, all children from 6 months of age till they turn 5 are eligible for a free vaccine under the National Immunisation Program. And the dose of flu vaccines for all ages is now 0.5 ml. There is no longer a 0.25 ml dose for young children. They have the same 0.5 ml dose as older children, adolescents, adults. And for adults aged over 65, the adjuvanted QIV is the adjuvanted, that is the enhanced vaccine using an adjuvanted dose rather than the high dose vaccine that we've had previously. We've had both of them available in some years, but we now have adjuvanted quadrivalent vaccine. So no trivalent anymore for people over 65. They're getting the full suite of protection of all 4 strains. And FluAdQuad is the only brand licensed and available and funded free for everybody over 65. Here is a breakdown of all the different flu vaccine brands that are available in 2020 by their age group, and it shows the different indications of which brands are licensed and available for which ages. And just to note, age 65, all the strains are licensed for use in age 65, but it's only the adjuvanted vaccine that is the preferred dose to give them. That is because it gives a higher protection for that age group, where these are not adjuvanted and do not elicit a strong enough response to give the duration of the level and duration of protection that we want for the over 65s. So this is the preferred vaccine for over 65s and not licensed for younger. To remember that that the vaccines that are funded for all Indigenous people, pregnant women, and people who have certain medical conditions, and we'll detail that in a moment. Here is a list of the 4 strains that are in this year's vaccines. The 2As are the H1N1 and H3N2. They're similar to previous H1N1s and H3N2s, but slight variation in the H3N2 being considered significantly different, but still based on previous H3N2s. And the B, both lineage of Victorian Yamagata lineage represented in the Washington and the Phuket strains. The highlights also, we mentioned that there is a new brand that is quadrivalent newly registered. That's the Vaxigrip Tetra. FluAdQuad is an adjuvanted quadrivalent vaccine for people over 65, we mentioned. FluQuadri was previously registered for adults and children from 3, and now it's been extended to extend down to 6 months of age. And there's no longer, therefore, any need for a FluQuadri Junior, which was that previous 0.25 dose. And Influenza Tetra is a quadrivalent vaccine previously registered from 18 years of age, and it's now indicated registered from 3 years of age. Final points are the timing of vaccination is always a tricky issue because we know that the peak performance of vaccination is within 3 to 4 months following vaccination, and then it starts to wane, and it can wane differently in different people. So immunocompetent people probably have longer duration of protection, possibly 6 to 9 months. We used to think it was longer, but probably starts to wane at that time. But in immunocompromised people, then there is an issue about how well does the vaccine duration of protection last. We think from the last few years that we've been using enhanced vaccines, both high dose and adjuvanted, that we're getting longer protection than this would suggest, and we're hoping that's the case. Because, of course, if we give the vaccine too early, then we don't get the protection at the peak protection at the time of peak exposure, particularly for longer duration seasons. But then again, if we don't give it early enough, then we miss out on protecting during the early interseasonal flu infections that circulate. So there is no absolute right and wrong. The general recommendation is that it should be done from mid-April onwards, vaccination in general, but can be given earlier, and you can't give it earlier than we receive it, but we have had some vaccine available now, and we're starting to roll it out actively, particularly because we want to get in before COVID infections dominate, depending on what direction the curve goes for that. So vaccination should continue to be offered as long as the virus is circulating and the valid vaccine is available. And revaccination later in the same year has not routinely been recommended. It may benefit some individuals, certainly travellers who travelled prior to the other vaccine being available, and during pregnancy. We want to vaccinate as early as possible in pregnancy. Well, there's not much travel happening now, but we'll hold our breath as to see how long the season's going to go, whether any revaccination is going to be recommended later in the season, but at the moment that is not a recommendation. For pregnant women, a very high risk group is pregnancy for both mother and baby, and to vaccinate at any stage of pregnancy, and it's funded free for all pregnant women throughout Australia. It can be given at the same time as pertussis vaccine. But if they didn't get it earlier, then they could get it at 20 weeks when the pertussis vaccine is given for pregnant women, 20 weeks onwards. And if a woman was vaccinated with flu vaccine before they became pregnant, then revaccination during pregnancy is recommended. Government-funded vaccine for people with medical conditions associated with increased risk of flu complications are listed here. And these are examples of the type of conditions that render these people at higher risk of complications in the event they get a flu infection. And this is the list that we follow, and it is the difference between a funded vaccine and a non-funded vaccine in anybody aged 5 to 60 till they turn 65. So therefore, to summarise, the ATAGI recommendation from that statement we just read said that the optimal protection is for the first 3 to 4 months, and revaccination later in the same year is not routinely recommended. And in Victoria, it's been stated that the vaccine should be given any time from mid-April onwards, and this statement was made prior to the to COVID circulating. So we just have to, I think, vaccinate at as early as we can in terms of vaccine availability and manageability of a vaccine program. Vaccine supply is an issue. You can't vaccinate everybody at once, and you can't vaccinate anyone with a vaccine you don't have. So we just have to manage that as best. Just before we finish flu, a very quick point of perspective, just to have a look at the importance of flu vaccination in any given season, any normal season. I think we had to go back to 2012 to find a normal season, but the normal perspective of vaccine preventable diseases and the number of infections that occur in a year. 2012 it was only 44,000, it's nearly 10 times that. but pertussis, pneumococcal, these are the big three in terms of vaccine-preventable diseases in numbers in the year. And then these other ones are important as well, but just have a look at the relative perspective. As well as that, the very important effect, that is the positive outcome of vaccinating with flu to people who have coexisting disease. So we're very good at vaccinating people over 65, but we're not very good at vaccinating people who are at high risk of flu complications who are under 65. But look at the impact if we do vaccinate. We prevent 65% of strokes simply by vaccinating a person with risk of stroke. Respiratory disease, understandably, and heart disease looks low down here. This is actually 22% of deaths prevented for people with pre-existing heart disease just by having a flu vaccine. Now, when you consider that that's pretty similar to treating their lipids, lowering their blood pressure and stopping them smoking, this becomes a very important intervention of preventing disease in a high-risk individual. And the other high-risk conditions, so these circles are just around cardiovascular disease, metabolic disorder, mainly diabetes and obesity. Those are predictable high-risk conditions for people who are severe enough infection that puts them in hospital. But this is an alarming figure. On top of that, this purple represents females aged 15 to 44. So this is the percentage of females aged 15 to 44 with lab-confirmed flu that caused them to be hospitalized. They were that sick. And a third of them, their pre-morbid condition, besides being female aged between 15 and 44, was they were pregnant. The other alarming figure on this graph is that this is children in green, and nearly 50% of children who got sick enough to be hospitalized with lab-confirmed flu, their predisposing condition was nothing. They were perfectly fit and well prior. So children are at particular risk of severe flu if they get it. And in terms of numbers of cases, children under 4, and the younger they are, the higher the percentage of hospitalizations to cases, the high circulating pool in the community that then infect the elderly, grandparents, and they're the ones who are at higher risk of serious disease and death. So vaccinating children is important to protect the children and their grandparents. So finally on flu, before we finish this section, what's coming? Well, we've got our adjuvanted and quadrivalent flu vaccines for people over 65, so that's here. We've got live attenuated influenza vaccine in a nasal spray that may be coming in the next couple of years, indicated and highly effective in some groups. And we've got long-acting flu vaccines on the horizon that we hope will be coming in the next few years. And the other kid on the block is the respiratory syncytial virus vaccines. RSV is now the condition at Children's Hospital in Victoria that has replaced flu as the greatest cause of hospitalisation in children under 5, with now that most of those children are being vaccinated with the funded program. So with flu, moving on to pneumococcal vaccine. We'll take questions at the end, I think, so please write them down and we'll deal with them after. So pneumococcal vaccine is a complicated area that's poorly dealt with in the handbook, and consequently it's important for you to know how to get the answer for a very neglected group of people, and that's high risk for pneumococcal disease. The issue is that we now have and I'm talking about adult here, so this is the context of adult. Children are relatively straightforward at 2, 4, and 12 months of age, or 6 weeks of age for the first one. So the Prevnar 13 program for children is straightforward, but for adults, it's now recommended for adults with the highest risk of invasive pneumococcal disease. We'll refer to them as category A in a moment. This Prevnar 13 pneumococcal conjugated vaccine is recommended for adults, but not funded for adults. who have the highest risk of invasive pneumococcal disease. The traditional Pneumovax 23 for adults doesn't work that well in young children, is used as a booster dose for children at age 4 who are the high-risk children. But for adults, Pneumovax 23 has been recommended at various times as a one-off dose, as a 5-yearly dose, and now it's been refined over the last couple of years, and I'll demonstrate that to you. So first, to define who's the risk of invasive pneumococcal disease, and that is children under 2 and the elderly, all Indigenous Australians, individuals with the following risk factors that place them at category A being the highest increased risk group with these conditions, notably immunocompromised condition, either due to disease or immune suppressive therapy, and these congenital and other disorders here. And the category B are those with an increased risk, just not considered the highest increased risk conditions. And these are more those classical for flu, indication for flu vaccination. And tobacco smoking is not one that is listed for flu, but is for pneumococcal, and is probably the single greatest group of cohort of people coming through our doors each day that we see for whatever condition, who we should be focusing on for a vaccine that we might not be. So the recommendations are quite complicated, and I won't step through them because I'll show them to you on a chart in a moment, which will help enormously to understand. But just to be aware that there are recommendations for Pneumovax 23 at age 65 and for non-Indigenous Australians from age 50 for Indigenous, and all Indigenous from 15 onwards with medical risk conditions, and all children at 4 to 5 years of age with medical risk conditions. And where adults are recommended the 23-valent polysaccharide vaccine, but are not eligible under the National Immunisation Program, they're best to receive a PBS script, as it's cheaper for them if they have that indication. So I'll demonstrate that on 2 charts. This chart is the Immunisation Coalition chart to try and put those complicated recommendations into a display that we can follow. And this helps, but you see there are a whole lot of qualifications and dose intervals that vary depending on which what sequence they get, and so on, as to a 13-valent Prevnar or a 23-valent Pneumovax. And the next chart was circulated from by BioCSL, which is now Seqirus, to try and demonstrate the different vaccines and where and how they're funded. So those 2 charts are available, but by far the easiest way to identify is to think SMART, that is PneumoSmart. This vaccination tool, by simply clicking in a few places, will lead you to enter the age and the Indigenous status, the smoking status and the medical condition, and it will then tell you exactly the schedule, the complicated schedule for a patient sitting in front of you, including the future dates to give the vaccines. And I guess this slide summarizes better pneumococcal vaccination for adults, although this slide could also summarize anything in immunization these days. I want to just mention briefly adult hepatitis B vaccination, as it is highly prevalent in the world, and up until recently, Australians travelled to all these places very frequently. We're on hold for a little while, but when that resumes, you'll see why the recommendations for hepatitis B vaccination are as they are. Just to be aware that the hepatitis serology is complicated, and it also is counterintuitive for identifying, interpreting blood tests for serology. So while the blood tests can be very helpful, there are circumstances where they're misleading. So the serology for interpreting hepatitis B, the table for interpreting hepatitis B serology helps to identify the different categories of hepatitis B susceptibility. So if they're negative on all three of the antigens and the antigen and the antibody tests, then those are people who should be vaccinated. There are some that the serology will indicate previous hepatitis B virus infection that's resolved. There's serology will identify where vaccination has occurred, but there can be misleading results if that is negative, because the level can appear to fall, but a person may remain immunised, and I'll demonstrate that in a moment. Where they are positive on the hepatitis surface antigen, that may indicate that they've got active hepatitis B infection, and they may be carriers, yet they would be negative on the hepatitis B antibody test. And certainly in this indication, there can be a number of different possibilities. So what this means in principle is that the aim for confirming serology is to time it right and to interpret it in regard to how many previous doses of confirmed doses, documented doses of hepatitis B vaccine have been received. So the recommendations for hepatitis B vaccination is all infants universally, and that's been in place since 2005. All Indigenous Australians, people who are immunocompromised, including those reasons, people with medical risk factors as listed there, as well as people whose circumstances increase their risk of acquiring hepatitis B, so household contacts of carriers and sexual contacts of people who are carriers, men who have sex with men, migrants from hepatitis B endemic countries, and that's most of the world other than the United States, Western Europe and Australia, and drug injecting people. As well as that, people whose occupation increases their risk of acquiring hepatitis B, which is all of us, members of the police, armed forces and emergency services and correctional facilities, people with developmental disabilities, funeral workers and tattooists and body piercers, travellers to hepatitis B endemic areas may be at increased risk, particularly if they sustain a cut or something, and the sterility of the facility where they're sutured may not be up to standard. So eligibility criteria for the free hepatitis B vaccine in Victoria includes all of these people, and that includes whether or not they have a Medicare card. That's listed there. So I now want to move to cover an area of importance for general practice, doctors and nurses, and that is the vaccine safety surveillance and reporting of adverse events following immunisation for us to, and what our role is in this. So we know that disease surveillance for vaccine preventable diseases are all represented. Here's the graph we saw earlier on with regard to measles, and you can simply drop down that box and select whichever disease is notifiable in Victoria, including all vaccine preventable diseases. And you can search it in various ways, but this is all districts, and it shows a representation of what the surveillance is showing at the moment. This is now, so that's surveillance of disease. This is what we want to look at as surveillance of adverse events following immunisation, and this has not until recently been very well in place. We've relied on passive notifications of vaccine reactions. That is, someone gets a vaccine, then they get a reaction, and then someone reports it. That is, they link that the two have been done, yet the person that is seeing them for the reaction may not have been the person or the practice that provided the vaccine, and it may not be picked up. So we've been under-reporting, perhaps. We now move to a stage of active surveillance. I'll explain what that is. Just to give you an example of the importance of the type of reported vaccine errors that we've had, in 2017, we actually had a death following a funded ZosterVax vaccine in a 70-year-old male who had an underlying condition for which they were contraindicated. So they were in the age group that was funded, but they shouldn't have got that vaccine. Live vaccines are contraindicated where immune deficient or suppressed. And the ZosterVax is indeed a live zoster vaccine with approximately 15 times the dose of varicella zoster virus as in an MMR vaccine, as in a varicella vaccine. So that death was tragic, and it's still being sorted out as to how that could have been prevented at the time. And I'll demonstrate. In fact, I'll come back to that in a moment, just to show you the other areas of particular interest. In 2010, there was a brand of flu vaccine that resulted in children under 5 having 10 times the usual reaction rate for fever and febrile-related convulsions. And that was not picked up immediately because of the lack of an active surveillance program. And that was the stimulus for the production of the active adverse event program, which I'll show you in a moment. MMR vaccines, we had a number of third doses being given to children when the schedule changed a couple of years ago. And because of confusion, or rather the potential for confusion if the schedule wasn't followed actively, if it was just routinely given, they may have had an extra dose. Didn't cause any particular harm, but it was inadvertent and potentially not a good thing to be doing. We still have occasional reports of rotavirus vaccine being given to children outside of the recommended age window. Rotavirus vaccine is one of the few vaccines that have very strict age windows beyond which it's contraindicated because of the higher risk of intersusception occurring in children older than the recommended age windows. And on this list, just to demonstrate a relatively new vaccine reaction that is related to the incorrect placement of the needle in giving vaccines in the deltoid, and it's called SIRVA, shoulder injury related to vaccine administration. So just to step through Zoster, ZosterVax is generally a safe vaccine, and you can see on this report for OSVAC safety, that is the active surveillance program, that the majority of people, 92% of people who have a zoster vaccine, age 70 to 79, have no reaction whatsoever, and only 8% of people have a reaction, with 0.3% being in blue here, representing severe enough to require a medical attendance or medical attention. So normally a very safe vaccine, but not so, just missing a slide there, zoster vaccine. So this is the latest data from 2019, and out of 1,557 people who reported vaccine, there is a 92% no reaction rate, that is active reporting. Those people were asked and they answered, no, I did not have a reaction. 8.3% said, yes, I did, and this is the breakdown of it. As I said, 0.3% is severe enough to need medical attention. But that did not pick up in that survey the individual who unfortunately died from being given the ZosterVax vaccine when it was contraindicated. And so that warranted the issue of ZosterVax and a special alert about ZosterVax, people who are immunocompromised, that came out in 2018 to help guide us. And there are various guides to what levels of immunosuppressive medications are tolerable and what action is needed to be taken for that. The other we mentioned is the shoulder injury related to vaccine administration. It's where the vaccine is given either too high or too low around the shoulder joint, and can cause shoulder pain and restricted range of movement for a duration of time from weeks to years. And it involves soft tissue injury around the rotator cuff. Either can begin at the time of injection or a bit later. So just to emphasize the important location and correct positioning for giving a vaccine in the deltoid that isn't too high or too low, and the anatomical reason for that, and the correct triangle of safe administration for a vaccine, and the reporting. So now I just want to focus on reporting of vaccine reactions. It is part of routine vaccination procedure to inform people that minor vaccine reactions are common and usually involve local injection site reactions or mild systemic reactions for a couple of days, but serious adverse events can occur, and part of routine consent is to inform people of that. And there's the chart, what used to be on the inside cover of the handbook when the handbook was a hard copy. Now it's in tear-off pads that are supplied free by the Victorian Department of Health, and it looks like this. The front of the page is the pre-immunisation checklist, which should be given to every vaccine recipient to read prior to vaccination, together with whatever the disease that's relevant for the vaccine they're having today, and the comparison of the effects of the disease with the side effects of the vaccination. And this would be the minimum information needed to inform someone prior to a vaccine of what the risk is. Just to blow up that section to include the flu, and you'll see here that it does mention Guillain-Barré syndrome occurring about 1 in a million following a vaccine. What's not mentioned here is the incidence of Guillain-Barré in a person who doesn't have a flu vaccine is also 1 in a million. But it's mentioned because in the 1970s, there was a pandemic flu vaccine developed that had about 10 times that level occurring that year, and only that year, but we look out for it every year. Post-vaccination, it's routine to give a tear-off sheet of the common reactions and what to do about them, and that's also supplied free by the Department of Health. If we are reporting an adverse event, then we report in Victoria to SAFEVIC, also known as AEFI, and it is located at the Children's Hospital and can be notified online or via a form faxed or emailed to them. And it's a simple form to provide some details. And this is how we notify the SAFEVIC program, which contributes the Victorian data to ADRAC and is analysed. And to report a person to the service, you can do that, and that's the mechanism to do it. And so we move to this area that I mentioned of active vaccine surveillance for reactions, and that's using a government sponsored NCIRS hosted AUSVAC safety program. And that program is collecting active data, that is, people who participate send a text message and they reply whether they did or didn't get a vaccine. And this is something that may be relevant for all your practices if you aren't already involved. The reporting is very, very high level. So we get reports of, for example, flu, just to step through. The level of detail, we saw similar display for the zoster. This is now flu vaccine, 6 months for 3 years, and it shows out of nearly 25,000 replies from vaccines given. That is, these are responses to the text messages. 94% said no reaction to my child. We're following the vaccine 3 days after the vaccine was given, 6 months to 3 years of age. 6% said yes, but only 0.8% was severe enough to need medical attention. And this is the breakdown of the 1,500 of those 25,000 who reported any reaction. That's in the blue. These should be blue, I think, but anyway, that gives an indication of the relative reaction that they had. And as we step through the different age reports, 3 to 5 years, 5 to 18 years, we're seeing very high level safety data with very high numbers of reports of actively being asked yes of being asked and replied yes or no. And so very safe. And through all the age groups, we see 18 to 65 years, a similar level, and over 65 years, even with the enhanced vaccines given in 2019, very high level safety with no reactions reported in 94% of people, and those who 6% who reported a reaction. In total, only 0.3% needed to report that to a doctor. So very high safety. In pregnant women, similar high level of safety and tolerability, with nearly 4,000 women responding pregnant women responding following their vaccination. So vaccine safety at that level of report is what we're collecting in these active surveillance. And this program, AUSVAC Safety, applies not just to general practice, but has been predominantly in general practice, but also hospital networks in Australia, and more and more practices coming on board where people who have a vaccine seamlessly, part of the notification of the vaccine in your medical software, that automatically feeds to the collecting agent, sends a text message automatically from the ostensibly from the practice, but at no cost to the practice, saying yes, thank you for having vaccine at our practice. Did you 3 days ago? Did you have any reaction? Yes or no? And a very simple reply mechanism collects data. It collects data for any vaccine being given and presents reports on the routine NIP schedule, 2 months and 4 months and so on. In general practice, the conduit to AUSVAC Safety is a program developed by a GP in Western Australia called Alan Lee, and that was called SMARTVAX, SMS Adverse Reaction to Vaccination Program. And this is simple text message that gets sent in the mechanism I just said, a very high response rate, and patients who participate are all appreciative of that. And so simple reply generates further text message if they answer yes, and only if they answer yes, to determine the severity, the nature, duration, and severity of the reaction. This isn't what they see. This is just a charted representation of the questions that are teased out in just a very couple of screens that they see on their smartphone. Only takes them a moment to answer. Practices that participate are provided quarterly with a display of their practice performance compared to their state and national figures. And so you can see for our practice, for the period of, I think I've got an even more up-to-date period, but the figures are about the same, that show the number of no answers, that is no reaction whatsoever. The blue is the reactions, and the subset is how many people had a reaction severe enough that they needed to report it to a doctor or get medical advice. So very high tolerability, and you can demonstrate live, current, local, that is your practice, performance, and this is from all vaccines pooled, including travel and everything else given. So the high level, just to magnify that out, to show the level of reactions in the practice. So 93% of people had no reaction, and this breakdown gives a slight variation in terms of age and replies. So very relevant, very easy to introduce. And when practices are invited to participate, don't hesitate to put your hand up for that. So now I just want to finish where we started, a brief step through where we're at with COVID-19 at the moment, and then we'll finish to take questions. So even though this is not a vaccine preventable disease yet, we're all hoping and relying that it will become a vaccine preventable disease, perhaps on next year's session. But in the meantime, a heads up for what's affecting our other vaccine preventable disease programs. So Victoria, these are up to date as of today rather, this morning, and that is global, Australia and Victorian cases. and we see the actual crude case fatality rate. If you do the figures on this, we're looking at about 1% of cases in Victoria and Australia are fatal. That is, cases that are confirmed positive ending up in a death confirmed due to coronavirus. Now, that crude case fatality rate of about 1% may underrepresent the number of cases because of our tight testing requirements. So we may have a lot of untested positives in the community that would dilute that number of 1% of case fatality rate, but we can't include what we don't know, and so this is the representative figure. Around the world, the cases on average are 6%, 6.6% on these figures of case fatality rate, but there's huge variation of accuracy and meaningfulness around the world in terms of number of number of tests available, quality of the tests available, criteria for testing, and so a country that reports no cases doesn't mean they have no cases and no deaths, just means they can't elicit them. So stay tuned for further progress. It's a daily changing statistic. You can download yourself or check each day world figures, either WHO dashboard. The Johns Hopkins Uni has in Baltimore has been very reliable at updating figures. That's if you want to see the world dashboard. In Australia, we now have a dashboard from the last week that displays everything on the one screen, including state-by-state breakdown, the numbers of current cases in intensive care, the number of daily new cases that are reported, that's known as the incidence figures, and we can see the curve is definitely shaping much more favourably than we expected when we gave part one of this talk a month ago, when it was up here, and we didn't know which direction it would go. This is looking good, but don't. By the way, this is the spread of age for confirmed cases, but this is the deaths by age incidence. So you can see majority of cases are between 20 and 80 years of age, but the majority of deaths are in the older group. This is a source of infection where the majority of all cases are still in the people who acquired it overseas, and we're going to see that gradually shrink down and we hope local transmission doesn't increase too much. And that was the number of tests being done in the country. In total, we've done 370,000 with a positive result of 1.7%. Just to expand that incidence and put on it what the curve is doing in terms of cumulative cases, we can see that we are very hopeful that this is a flattening of that curve that in other countries has taken off tangentially. In Victoria, that last one was Australia-wide. Victoria is showing a similar pattern. So we're getting almost several times a week, we're getting an update from the Department of Health in Victoria of Health Alert and what the cases and the key messages are. And I encourage everybody to be downloading them on a daily basis. Our last official update of changing criteria for clinical indication for meeting testing criteria is expanded on the 14th to include these categories, and that's everybody with a fever or history of fever in the absence of another explanation for it, or acute respiratory infection with cough, sore throat, or shortness of breath. In addition, a more loose definition of respiratory infection for people who have these symptoms and are close contacts of a confirmed case or have themselves returned from overseas in the past 14 days. So this is broader testing now, and we hope to learn a lot more data, irrelevant data, as to see the true incidence in the community. Confirmed cases naturally need to be notified to the department, but we don't have to notify suspected cases until they're confirmed. But really important, and this is an area that's quite been neglected on a number of anecdotes and reports I've had, that people are tested and then sent home without any instruction. They should be isolated and consider themselves potentially positive until the test result comes back negative. And if somebody fits this criteria and is tested and isn't informed that they're considered to be a suspect case, may be spreading through the community even after having been tested, which is really inexcusable. And the information is downloadable from the department of what a suspect case is and also what isolation is expected. That was the one page, the brief summary, and there is the expanded version now, 30 pages, 33 pages, that is the full case information guidelines for GPs and health services that's updated in parallel with that previous one. So just a 5-minute overview of what is coronavirus. Here's an electron micrograph of a coronavirus showing this crown around it, which gives it its name. This is a side-on electron micrograph. I'm sorry. I think my kids have been fiddling with the slides. That isn't a side-on electron micrograph. Neither is that. But this is a real picture from the actual market in Wuhan, where the virus mutation occurred that enabled it to move from prior animal infection only to being a human spreadable disease. Lots of data has been studied now in the period between December and now, both in China, around the world, and also in Australia, in terms of trying to predict what the pattern of spread and what the determinants of interventions can be in the absence of vaccine or treatment, what will make a difference and what won't. And so this is a paper released last week in Australia, which is a pivotal picture for looking at it. Just a couple of words to focus attention on what our role is here and how we can help. And I'm grateful to Paul Johnson, Professor of Infectious Diseases at Austin Health, for a couple of these slides. But he succinctly pointed out that it's a new virus that is related to SARS coronavirus, but it is a new mutation and that it didn't exist before, but its closest relative is SARS. That its establishment in the community is not so much from its mortality rate, which we see is only 1%, doesn't sound too high, but the impact of a novel virus that we are all naive to is that we all get sick. We have the potential for it to spread rapidly and get sick all at once. So that 1% multiplied by a high percentage of the community, 1% fatality times a high percentage of the community in numbers, means big demand on hospital. The only treatment at the moment is oxygen, and you need it under positive pressure. And so the demand for respirators and ECMO services are very easily exceeded, and then people die. So they die from an excess of numbers, a bit akin to thunderstorm asthma. Thunderstorm asthma killed 10 people in one day, most of whom probably would have survived, but the services were rapidly over, demand was exceeded the supply, and so people died that otherwise wouldn't have. So in the coming storm, and we hope there won't be as big a storm as we saw because of our success in flattening the curve, but our role is to try and change the natural history of high numbers presenting early above our level of threshold of being able to cope in the healthcare system, and pushing it longer and flatter so that we only that we don't exceed too much our capacity. And that's what the flattening of the curve means. Just a couple of other insights that we have before we close this section and the talk for the evening is the pattern of clinical presentations, and we see the usual spread is very similar to mild colds, severe colds, influenza mild and severe, and every other respiratory illness. There's nothing specific that you can say this is coronavirus rather than any other virus. And anosmia is quoted in the lay press as being a sign. It really is only a sign of a severe blocked nose, and not necessarily pathognomonic of coronavirus. Who is most at risk of contracting coronavirus? Overseas travellers, close contacts of previous confirmed cases, healthcare workers, aged and residential care workers. And so these are the highest risk groups for contracting coronavirus. And the people who are at risk of most severe disease, if they do get it, so this is confirmed cases, majority had no predisposing condition, but the numbers of deaths that have occurred in people with predisposing conditions are disproportionately high. And we're not sure yet whether this just represents the age breakdown that we saw, and the older you get, the more likely you have these conditions. Also, Indigenous people are at higher risk for severe infection if they get coronavirus. And here is the age distribution that is very classical, linearly, or rather exponentially, for age relationship to severe outcome. So our risk here of dying from disease is very low, but our risk up here, if we're this age, is much higher. We just saw that. And the ability for the virus to spread through the community is what affects its impact on society. So that's the R0, which is the reproductive number. An R0, it means that if it's higher than 1, it spreads. If it's less than 1, it doesn't spread. That is the number of people who are infected from an index case, the number of secondary infections. Untreated, the coronavirus, the COVID-19 coronavirus has an R0 of around 2.5 to 3. That means each person with it will infect 2 to 3 other people. We are currently, by our strategies of social restriction and hand washing and all of those strategies, have reduced it to under 1 in Australia. And so we are actually, that's why the curve is turning. The severity determines whether we should bother or not. Swine flu had a high R0, but it wasn't very severe, so it was a test case for the real pandemic that we have now. And the modes and patterns of transmission are important to identify what can we do. To put it on a scale, this orange box shows the estimated range for severity and infectiousness for this COVID-19. To compare it, this is usual seasonal flu, and 2009 swine flu pandemics were down on this level. This was Spanish flu, and it's in the ballpark of Spanish flu, but even a little higher in its spreadability and its severity. There's SARS, MERS, Ebola, and bird flu. Very hard to spread. This is spread how the R0 of how many people are infected by it. Very hard to spread, but if you get it, you have a high fatality. Measles, on an individual basis, not a high mortality, but very easily spread to people who are non-immune. So there's measles there. Here is where we are for COVID, looking at R0 versus death mortality rate. So there's our curve. This is what we're trying to do to push that over to help manage. And that's our role to socially isolate. The latest figures, as I hinted before, we will push the curve over and comply if we have over 90 compliance or even 80% compliance with all the social distancing rules and hand washing, PPE equipment for healthcare worker and so on who are in direct contact with treating cases. But all we need is 70% of people in the community to not comply, and we go off the scale like the US and we saw in Italy and Spain. So social distancing is important to do, and it is effective. Wearing PPE equipment is important, but certainly it should be worn correctly or it won't be effective. And we have a insufficient supply of personal protective equipment, so improvising might or might not be of any help there, and certainly ways of extending our supply are worthwhile exploring. And the final thing to close is that the government introduced MBS telehealth items, which have now been expanded for all practitioners, all GPs and allied health for, well, certain members of allied health for all people, and services bulk billed to certain groups, and with the recent extension, doesn't need to be bulk billed to certain other groups. Finally, just a plea, there is a plethora of articles and information coming out, some valid, some less valid. It is really important that we do not modify our behaviour outside of the guidelines or approved authorities, such as happened with hydroxychloroquine. And the Australian Rheumatology Association has put out a note saying, do not try this for people with COVID-19 unless they're part of a randomised controlled trial that is an authorised trial, because it is needed in people who it's proven to be effective, and it is completely uncertain as to whether it's of any benefit at all and may even be of harm to treat COVID. So despite what Donald Trump says, please do not use medications or therapies that are not approved for their use, no matter how good the article that you happen to be reading is. And my recommended reading at this time is not medical, or is not is enough of the charts and graphs, but to have a look at Geraldine Brooks' award-winning Year of Wonders of the bubonic plague, and people going through then what we're going through now. Ben Elton, Blind Faith, comedy in his usual style of teasing out hypocrisies in all of us, and Professor David Isaacs, paediatrician, New South Wales, Defeating the Ministers of Death, A Compelling History of Vaccination. So therefore, I'll now thank you for your perseverance to this point, and I hope we've got time for a few questions.
Thank you so much, Peter. So much information. You always love to jam-pack the session in, which is much appreciated. We do have a couple of minutes for questions, and obviously anyone who's dialing in, if you do need to leave, no problem at all, but if you're wanting to hang around for the questions, we'll run through a few that we have. All right, let's have a look. So one for Mary Ann. What are your thoughts on the increased uptake of, now apologies, Pneum 23 due to this COVID pandemic, especially for under 65s?
Excellent question, Marianne. I think it's important that you've raised it. It is an example of something that's got good sense. It sounds logical. It's got a valid rationale. The basis for pneumococcal vaccination in people in a time of a pandemic is because in the earlier Spanish flu pandemic, we know that pneumococcal disease complicated flu infection at the time. And so half the people who died from Spanish flu actually died from pneumococcal superinfection. It was pre-antibiotic times, and we certainly would be recommending pneumococcal vaccination for anybody who is indicated according to those criteria we said earlier in the program. However, there is absolutely no evidence to suggest that pneumococcal vaccination to anybody else will be of any benefit whatsoever in COVID-19. So the recommendation is it should not be that everybody should have Pneumovax vaccine because that's what we do for a flu pandemic. The recommendation, otherwise we'll find Pneumovax vaccine becomes like toilet paper overnight. And if Donald Trump was to announce that, there would be a disaster because everybody who should be having pneumococcal vaccine will miss out. So therefore, the recommendation is certainly Pneumovax 23 for everybody who is indicated to have it, not anybody else. Thanks for that question.
Okay, next question. How soon can we provide ZosterVax vaccine after a patient has suffered from shingles?
Excellent question, and it's 12 months to give you a quick answer. So the handbook does cover that. There's a section on the handbook about interval between having a shingles episode and a ZosterVax vaccine.
From Trudy, will Shingrix vaccine become available in Australia instead of the live vaccine ZosterVax?
Thanks, Trudy, was it? Thank you for that question, because that is the question I've asked myself every day for the last 5 years. Shingrix is the inactivated zoster vaccine, and I was an investigator on the development of the Shingrix vaccine program and worked 10 years on that in a cohort of 100 patients at our practice who received that vaccine. And it's of overwhelming benefit in terms of vaccine effectiveness and safety as well, and has potentially the role of being able to give that inactivated vaccine to people who are otherwise contraindicated. Unfortunately, whilst it's available in a number of countries in the world, it is not available in Australia. It's been licensed here for nearly 3 years, licensed, but not available. And there is no indication that it'll be coming available anytime soon. But if people want to travel over, well, when people could travel overseas, they could travel overseas and have it in the UK, Europe, North America, Canada, Japan, but not Australia.
Great. Question from Katrina. Is there any danger to giving Fluad Quad to an under 65-year-old?
So it's not like, and that's a very good question too, and one the short answer is it's not licensed to be given to people under 65. It is an enhanced flu vaccine equivalent to about 4 times the dose, that is giving 4 non-enhanced flu vaccines. Its safety has not been studied or approved for under 65, so no. But the other vaccines that are non-enhanced are licensed to give to people over 65. Say, for example, if there was no enhanced vaccine available, then one could give that. And if you were then found the enhanced vaccine became available, you would need a minimum interval of a month between receiving 2 flu vaccines.
Question from Donna. Donna works in corrections, and very often patients do not complete the courses of Hep A and B. Should these be recommenced or continued on from the last dose?
Thanks, Donna. So in a general principle in immunisation is that one doesn't need to repeat doses. So we would follow the schedule or the catch-up schedule, and the Victorian government has provided a lot of tools for catch-up schedules for different age groups. So you'd follow the recommendations in the catch-up schedules, handbook or Victorian government, and they would generally recognise prior vaccines and then build on it in terms of timing and numbers of future doses. Sometimes serology can be helpful for certain diseases, but serology is not helpful for all vaccine preventable diseases. So case by case, and yes, in general, you would continue the program where it left off, but or the schedule where it left off, but not necessarily needing to repeat.
Okay, and sort of just a bit of a follow-on question from Donna is that from a personal perspective, she's had 7 Hep B doses and still less than 10. Is she covered? And also she had the disease Hep A as a teenager, but now there's no serological evidence. Hep A as a teenager, should she be re-immunised?
So Donna, I don't mean to be personal, but you are termed what's called a non-responder to hepatitis B vaccine. Now, there's a whole chapter on non-responders and the different combinations, permutations, and different ways to approach it in the handbook. So have a look on the electronic version. Remember, everybody, I've mentioned the handbook. It's not a book anymore. It's on online. If you've got a book, that orange coloured, it was printed in 2013, and it's no longer up to date. So don't use a handbook in a book form, in a hard copy. use the online version. You can print sections of it from the online version, but they may be updated online and not updated on your sheet. So just be aware. The section is very detailed, very complicated, and you should read it, and you'll get an insight into the options for people who are non-responders. And many people, it doesn't mean they don't have protection, but some people it may mean they don't have protection, and you should be aware of how to approach that yourself.
Just a couple of questions now regarding the flu vaccine. Marianne asked a bit earlier around the numbers of lab-confirmed flu that we're having. Are we having lower levels of flu being shown because we've actually run out of swabs because of COVID, so able to do less confirming in the lab?
Sorry, say that again. Could we have low numbers because?
Because we haven't done as much testing because we've run out of swabs because of COVID.
So
have we been doing less testing and confirming, I guess?
Yeah. So no, I think that there's a lot happening in regard to understanding what flu is doing and the regard to swabbing. So swabbing for flu could be done if you had a physical swab and the person didn't fit the criteria for a COVID test. You could still test for flu, and we did earlier on, a month ago. We did many times. We tested, and the level of flu is still lower than corresponding prior season last year, but that was a very high season. To answer your question, though, I think I'd answer it this way. We have no idea what flu is going to do this year, and the amount of testing may be modified temporarily while we don't have a lot of swabs available. But we think that we would hope that we're not going to have as much flu this year because of the social isolating that we're doing and social distancing. And that means that we have less avenue to spread flu like we're hoping to do with COVID, and we'll get a side benefit from flu. But we don't know that. We hope that. We just don't know that until we study it. Yes, the more swabbing we do, and generally when a COVID test is done, it'll be done in conjunction with a respiratory multiplex PCR looking at other strains of other respiratory viruses like flu, RSV, and rhinovirus, and so we hope to learn a lot more about it. To answer your question, a whole lot of stuff might be happening there, and we really don't know for sure. But certainly the more we test, the more we find. But I think testing will reveal what flu does, only it will be hard to compare to previous years.
Only a couple of questions to go. One from Navdeep. Do we need to give 2 doses of ml flu vaccine to children under 9 years if they are being vaccinated for the first time? Previously, we had ml dose for under 3 years.
ml being?
I'm not sure. It just says ml. I'm not sure what that's.
So I'm not sure what you mean by ml, but I think the question is a very good question about how many doses to people under the age of 9, and you're absolutely right. And it's got that in the ATAGI sheet that all of you will have received from the government and can download from the website. And that is any child under the age of 9 who are getting flu vaccine for the first time needs 2 doses with a minimum interval of 4 weeks. So whether that, will perhaps, if you can let us know what the ml refers to, but regardless of which brand, any flu vaccine given for the first time to a child under 9 is a 2-dose schedule. Once they've had flu vaccine in any season, whether it's 1 or 2 doses, subsequent seasons only need 1. That's a change from previous recommendations, changed about 2 years ago. Prior to that, they recommended 2 doses for any child under 9 who hadn't had 2 in the previous season.
Great. And I think we're just one final question we've got time for from Gina. Is it okay to administer, I think it's Pneumococcal 23 and ZosterVax at the same time? We used to recommend 4 weeks apart for less efficiency if given the same time.
So it's not so much an efficiency issue that you raise, Gina. It's about tolerability, and so they do say that you can have a little bit more local reactions and fever if you give the two within 3 days of one another, but you can delay by 3 days. But there's no recommendation to have to do that, and so it's kind of recognised that there's a slightly higher adverse event, but it's not one that would contraindicate giving the two together on the same day.
Great. All right, I reckon we might leave it there for the night. Thanks for an extra 10 minutes there asking all the questions. I think most people hung in there, so must have been pretty keen to hear your responses on those. So thank you so much, Peter, for your time tonight, and everyone at home for spending your evening with us. As I said at the beginning, we will be sending through a post-course email that will have lots of different links and extra resources related to tonight's session. We'll also remind you about you can access a lot of immunisation information on the health pathways that you have access to within the general practice. So always don't forget you can look on there for really up-to-date information through there. And of course, there's a really important evaluation survey that if you can take a couple of minutes to complete that, it really helps us make sure that we get the education right for you. So I'll let you go and thank you very much, and we'll hopefully see you at an event soon.
Thank you.